Hello and welcome to Chapter 7. So, in Chapter 6, we looked at a couple of different chronic conditions associated with physical inactivity, and today we're pairing a couple other ones because they're very strongly associated with tobacco. So, most people who are chronic smokers display the following chronic conditions. So, let's get started. Now, to begin, we have chronic obstructive pulmonary disease. I will call this COPD from now on. It's a third leading cause of death in the US, and it's the second leading cause of disability adjusted life years lost. So, very serious condition. And it's multidimensional. So, it's paired by or it's joined by ventilatory impairments, abnormalities of gas exchange, and CV and musculoskeletal impairments. We're going to go through them one by one. Now, for ventilatory impairments, the main thing here is that there's increased airway resistance. Um, Now, expiration is especially affected um, because airflow obstruction due to the airways becoming smaller really impacts how air leaves the lung. And of course, lung volume is decreased. So there's just a lot of things that are affecting expiration there. Now, the work of breathing increases due to all of this. Hyperinflation, which means that there's a mechanical disadvantage for the inspiratory muscles, and then an increased amount of dead space, which means that there's a high ratio between physiological dead space and tidal volume. Or a more colloquial way to talk about this is wasted ventilation. So just breathing is not efficient anymore. Now, for abnormalities of gas exchange, we see the destruction of alveolar capillary membrane in people who have emphysema. And then ventilation, perfusion, inequality is a part of this. And all of this impairs diffusion and can cause hypoxemia during exercise. And in case you don't know what hypoxemia is, it's low oxygen in the blood specifically. Um, so that oxygen percentage level that you may see as a metric, in hospitals or just whenever you're testing it for yourself. That's what we're talking about here. Now, for cardiovascular and musculoskeletal impairments, um, COPD progresses pretty slowly. Um, So that's one of the more interesting things about this. We don't see all of these symptoms automatically, right? However, the person's actions, because this is progressing so slowly, leads to the following. So we have CV deconditioning, and main thing here is just, as their condition is getting worse, they probably don't want to exercise or do any type of physical activity because it's uncomfortable, right? Especially when breathing is uncomfortable. I mean, I'm sure many of us experience that just in general when we're doing like running training or hiking or trail running or skiing. I mean, when breathing is difficult in normal circumstances, that makes you kind of rethink like why you're doing it at the level you're doing it. So imagine how much worse it may be for them. Also, we get peripheral muscle deconditioning, wasting, and weakness because of what I just said. Um, they also see an increased accumulation of lactic acid at low work rates, um, which again compounds how exercise does not feel good when they do it. Also, reduced pulmonary vascular conductance from chronic hypoxemia, right ventricular systolic dysfunction of the heart, and then dyspnea or breathlessness. And we'll talk about dyspnea quite a bit. So, exercise management. Here are the goals of pulmonary rehabilitation, right? Just to kind of orient us with what's going to happen. Goal is to engage the patient to perform exercise at a higher intensity, thus increasing the potential for obtaining a reconditioning effect from exercise training. And this is probably the most difficult part. This is the hardest thing that you're going to have to do if you're going to work with someone with COPD. Um, Optimizing pulmonary medications. So there's probably a long list of medications that they take. So optimizing it for whatever helps them best. Desensitization to dyspnea and addressing fear avoidance. So here we're seeing the fear avoidance cycle again. Um, Again, being breathless is not fun, right? And when you have a condition that constantly, makes you feel that way, it's especially like you could easily see how people would want to avoid it and so therefore not exercise and because of that make their condition worse. So that's another thing you'll have to work through that fear cycle. And then also completing a cycle ergometer or treadmill exercise test to assess the causes of limited exercise capacity would be pretty helpful here. Um, just to kind of understand what you're working with and maybe give you like a base to start from. So, how does exercise affect them? What are some negative effects we see? Main thing is, as we talked about, expiration is more difficult. So, the impedance of that requires a longer time for adequate lung emptying. So this will most definitely mean that the intensity will have to be a lot lower because if it's higher and you need to breathe more to bring in more oxygen, then it's likely going to lead them to experience breathlessness, dyspnea. So um, yeah, just note that that'll take a longer time. Now, there's a very long list of possible drugs they may be taking. I have compiled some of the common effects, so this isn't all from one drug, I promise, but um, these are just some common problems that you may encounter depending on what they say they're taking. Tachycardia, so higher heart rate, palpitations, risk of seizures, muscle atrophy, osteoporosis, myopathy, including the ventilatory muscles, which again makes things worse when breathing is a problem already, intravascular volume depletion, leading to hypotension. So these are all possible side effects that you may encounter. Also, they may require oxygen therapy to maintain adequate oxygenation during exercise. And if I'm sure you can tell if this is the case, then they will have to be in a pulmonary rehab setting, and they will not be working with you alone, um, because you probably can't provide this for them. So we're mainly talking about exercise in a clinical setting for people who have this to an advanced level. Now, what do you do for exercise programming? So, as mentioned, complete a cycle ergometer or treadmill exercise test to understand the causes of limited exercise capacity and other coexistent issues. So, we should note here, if they have COPD, they probably also have other problems because they're probably not physically active, so they may be overweight, may be obese, may have diabetes, may have hypertension, so on and so forth. Or they may have one of the conditions we're going to talk about today. So doing a little test like this is actually helpful for these people. It can also reveal stuff like exercise-induced hypoxemia, hypertension, cardiac dysrhythmias, and MI, which hopefully it doesn't, or sorry, myocardial ischemia, which can potentially lead to a myocardial infarction. So it is important to do it just to understand limits and probably help you too as the exercise professional to see what you can do with them, what they can tolerate. And note here, since it does progress slowly, they may not have too many symptoms on a normal day, but exercise is what causes some of these things to surface. Now, interestingly, you may be thinking, well, okay, this population has breathing problems, um, and breathlessness problems. Why would we test them? Well, interestingly, the book notes that actually you can even do a max test with them. Um, and it's actually appropriate as long as there's safety and there's appropriate monitoring going on with it. Um, Now it's somewhat up to you if you want to do a treadmill or a cycle ergometer. Now, ideally, the textbook recommends that you should do a treadmill one because for the cycle ergometer, they may actually get more, um, I suppose, like tired, like there may be mechanical limitations, and so they can't complete the max testing. Whereas for a treadmill, other than being more familiar with walking anyway, um, they will likely have to stop the exercise at some point during the max testing because of pulmonary reasons, which again is what we're trying to get at, right? But again, it's up to you, depends on the person. Also, there are some contraindications out there. So, for example, um, if there are situations where their COPD starts to get really bad during max testing, you can stop. You shouldn't do it. If their pulse oximetry level is below 85%, that's also a contraindication and you should not continue. Um, so have something ready to assess that for them, whether it's like the finger one or if there are more accurate ones out there. And then if they also have an unstable cardiovascular condition, so if they have, dysrhythmias, heart failure, or some other history like that, this is probably not a good idea. However, if none of those are present, and if you think that this would work for your client specifically with COPD, then it's actually okay and it's possible. So, how does exercise benefit COPD? So, some benefits that we see, it facilitates ADLs in their life. Um, we also see some cardiovascular reconditioning, improved ventilatory efficiency and threshold, and then a desensitization to dyspnea and fear of exertion. So, there are other benefits, of course, but from here on out, and for most conditions, I will list the ones that are very specific to the condition, the one that the condition really affects in their lives. And all of this is definitely very important. So, as long as you can meet that first goal we talked about having them do regular exercise, then all of this can occur and it would lead to them not being as scared of being breathless, breaking that fear avoidance cycle, and in general, living their life better because the movements they have to do, the ADLs they need to do, are a lot easier now. So, in terms of exercise programming, the main recommendation here is that, if possible, they do this a center-based workout. So, a place that includes an occupational therapist, a physical therapist, certified exercise physiologist, respiratory therapist. So, if possible, doing this in a center that is equipped with all of these people may be very important. And you may be one of these people at that center, right? Um, Also, an intensive program is recommended, um, just to help them get over that hump of starting exercise. And then there aren't any very specific recommendations here. I mean, CDD4 recommendations are the ones. The mode of activity should just include large muscle groups and be comfortable for the client. Um, the intensity has to be based on RPE or their dyspnea scale. So that will be very dependent person to person, and you'll probably learn, and they'll probably be very vocal about what they're able to do. Also because of the dyspnea and depending on how severe their case is, some form of intervals would be very helpful for this population. One, because you can give them breaks, but two, because they probably, when they start with you, they won't be able to do sustained exercise for more than 5 to 10 minutes anyway. So, um, so starting with intervals is a pretty good idea for them. Also, again about the oxygen, administering it um, if the amount is less than 88% is very important. So this is why it's recommended to do this in a center that's equipped with everything and people who understand how to do it. So that is COPD. Um, Now, why don't we talk about probably the most important thing? Maybe we'll talk about the whole semester. Um, Coronary artery disease and atherosclerosis. So we're pairing these together because typically atherosclerotic buildup leads to coronary artery disease and other issues that we'll talk about later in the year. But CAD, or coronary artery disease, is the number one cause of death in the world. It's very serious. The American Heart Association estimates the following developments of CAD symptoms. So they estimate that about half of all Americans um, under the age of 55 years old probably have some form of this, some form of the symptoms. And then 33% of all American women under the age of 65 have this. So, yeah, a lot of people get affected by these symptoms. And what's especially scary about CAD symptoms is something called silent ischemia. This is um, 3/4 of all ischemic episodes, and these are the things which lead to myocardial infarctions or sudden cardiac death with no warning signs. So maybe you guys know people in your lives that have had something like this, that they just suddenly have a heart attack and they didn't really have maybe some of the precursors that would lead to it. They didn't have any indication anything would happen. Um, this was likely what happened. And I know that, I mean, I don't know how different we are in age, but my parents' generation is the one that's really starting to see this happen to, their friends. Like they'll have friends and every couple weeks, every couple months, you hear that someone had some type of an episode, maybe like a light heart attack or maybe some type of a cardiac arrest, some type of something happening. And sometimes they know why, like they have hypertension, they, had a history of heart problems. Sometimes it's very sudden and no one knows why it happened. So, perhaps this doesn't impact us right now, but it definitely will in 20, 30, 40 years. So, what exactly is it? Well, atherosclerosis is described as the accumulation of fibrous plaques on the walls of arteries that supply oxygen to the heart. And specifically, this happens to arteries that are experiencing a very high systolic blood pressure. Um, so, there's just like a high amount of pressure passing through them. So, the way that it happens, a typical like sequence of events is that there's some type of an injury to the endothelial lining of the arterial wall. And I mean, whenever you get any type of an injury, like a paper cut or whatever, um, the body starts to heal it, right? So platelets come to adhere to that injury site and they release growth factors to heal it. However, LDLs, remember we talked about that last chapter, LDLs get attracted to that site. They oxidize and they attract immune cells and that transforms into a fatty streak. And then that develops a rigid fibrous cap. Now, the problem isn't that this cap can stay in the like in the artery where it's building up. The problem is it can break off. And if you have this chunk flowing through this artery, you don't know exactly where it's going to go. It kind of just depends. It's a bit of, involves a bit of luck, unfortunately, but it can get stuck somewhere that is a lot smaller than where it developed. Um, so this is like the general way it happens. Again, I'm sure you guys have heard this explanation before, but just refreshing memory if you haven't. And there are some things that you can't control in regards to the risk of developing all of this. And there's stuff that you can control. So the non-modifiable ones are age, sex, and then family history of premature CAD. Um, yeah, so the older you get, more possible that this is. Um, and yeah, family history is a very big one. This is why your doctors ask you if, there's been people in your family that have heart issues. Um, However, there's a lot more modifiable risk factors here. So, hypertension. So, think about it. If there's more pressure through these arteries, then the cell walls are experiencing a lot more, I guess, load, which can just cause those lesions to occur quicker or more often. Dyslipidemia. So, more amounts of lipids in the blood flow, can attract to those sites. More. Physical inactivity, which we've talked about extensively. So smoking, of course, obesity, and then diabetes. So all of these are the things that you can help to not, you know, predispose you to CAD. and or atherosclerosis. Well, or atherosclerosis. So in terms of management and medication, so there's a very, very long list of medication that people can take. So I've compiled some of the different effects. So some of the physiological effects we see of medication people may take for this decreases the heart's preload, decreases heart rate, decreases afterload, and then peripheral vasodilation. So those are some things that it tries to do to help out with it and, lower your risk for adverse effects. However, some of the side effects we see for exercise specifically is increased heart rate response with decreased aerobic capacity, decreased peak heart rate, ergomimetic properties that facilitate cardiac output. So we have a few bad ones, and then we have a few good ones. So kind of like the talk we had during hypertension. It really depends on what medication they're taking. So definitely ask them. And this book has, again, a pretty good table that relays exactly what type of drug does what. But yeah, talking to them to see which drug they're taking is very important for their effect on exercise. Now, here's the things that we see in their exercise response. So, if they have a sufficiently advanced level of CAD, their aerobic capacity gets decreased 40 to 60% of their age and sex predicted capacity. And this is mainly due to diminished cardiac output, so either heart rate, stroke volume, or both. Also, decreased contractile force of the left ventricle leads to a loss of ejection fraction and stroke volume, which then leads to exertional hypotension. And that's when their blood pressure starts to drop while they're doing exercise. So, yeah, it definitely affects exercise. This is one of those conditions that will affect how you program things for them. Now, again, exercise for basically every condition we talk about can improve a lot of the symptoms that they have. So, it does a lot more than what's here, but again, these are pretty specific to CAD. So, ventilatory response to exercise and ventilatory threshold all can increase. Their VO2 max can increase in an average of 20%, which is really great. I mean, granted, they're probably starting from a low level, but hey, the 20% is really good. Protection against myocardial infarction by physical exertion greater than 6 METs, so just increasing that threshold right there. Decreased coronary inflammatory markers, so they usually see this when like the doctors do testing, not quite you. Um, Increased cells that promote angiogenesis and vascular regeneration. And then decreased blood platelet adhesiveness, blood viscosity, and among other things. So again, a lot of benefits to exercise for these patients. And I think just a note here too, I think there's a very, um, I guess it's fair. There's a fear in these people that, oh, well, my heart is having these problems. I don't think exercise is going to make it any better because you're working out that muscle and it's just people start to get scared, right? They start to have some fear. So this is where your education really has to come in here and play a big role in dispelling anything that, any hearsay that they have. Like again, I don't know if you guys have experienced this, but my parents' generation is really like really suspicious of exercise, I think, if they have some type of heart problem. Or, a um sudden myocardial infarction happens in one of their friends and suddenly they think, oh, well, exercise isn't good for this. It's going to make it worse and you should just rest, don't do anything. So really take a note of these improvements and maybe have it handy. Memorize a few of the numbers, if anything, like, increase VO2 max by 20% or, whatever it may be, because it could very well help them, really control this condition and avoid any sudden death events. Did I skip? No. Okay. Um, so now in terms of exercise programming, so if there's minimal severity, so the book gives an example, post-angioplasty with no cardiac damage, then ACSM guidelines are fine. You don't have to, be specific about what exactly you're doing. However, if it's high severity, so they've had congestive heart failure with valvular heart disease, then the CDD4 recommendations would be appropriate here instead. Also, this is ideally in conjunction with a cardiac rehabilitation clinic or, a specific person who's trained in it. If the person can't do this in a cardiac rehab center, then a clinical exercise physiologist is another good option. And again, these people might be you specifically. Like maybe this is what your goal is with getting this master's. Um, so that's the note. However, you probably will still see people if you're not in these clinical settings, who maybe have the predispositions, or maybe their doctors have told them, hey, you have atherosclerosis, or whatever. So just note it and remember it's very person to person. Okay, now we talked about coronary artery disease. Now, what about peripheral artery disease or PAD? Um, This is caused by the same problem, atherosclerosis. However, it's not affecting the coronary arteries, it's affecting the lower extremity arteries. So, in a way, I did say luck was involved a little bit. Um, yeah, I mean, it's still not good. You don't want to have either of these conditions, but this is I guess the better part of it if you have to pick one. Um, Characterized by atherosclerotic lesions in the arteries of the lower extremities, and the main issue here is that it restricts distal blood flow. Um, so while it doesn't pose threats to the heart yet, people who have PAD actually are associated with a 2 to 6-fold increased risk of coronary artery disease and a 4 to 5-fold increased risk of strokes because, again, the primary mechanism of it is still atherosclerosis. And again, if that breaks off, you don't know where it could get lodged and, might get lucky and it gets lodged in the leg. Um, or you get very unlucky and it lodges in the brain or one of the heart vessels. Like you never know, right? So it's a very important condition, but yeah. So some risk factors for people developing this is, of course, smoking, given the chapter, hypertension, diabetes, dyslipidemia, and age. And again, think of the ones you can alter here. You can alter all of them except your age. So there's a lot of ways to avoid this in the first place. Now, some symptoms that they experience, it's quite different than anything we've talked about because now here we have intermittent claudication. So this is aching, cramping pain in the lower extremity that can involve the calves, thighs, or buttocks, or a combination of them. And it gets brought on by exercise and it subsides with rest. So it's just one of those conditions where if they're not really exercising, it might not be a problem. But when they do exercise, it becomes a real problem. So you can think about this again, like logically. If exercise is making them not feel good, they're probably not going to want to do it, right? Because that's what they associate with exercise. My pain starts, right? So you may have some fear avoidance cycles to break here as well. It's also graded on a scale from 0 to 3. So 0 is asymptomatic, um, and then up to 3 is minor or major tissue loss from the foot. So yeah, it could be pretty serious um, for this condition as well. Now, for exercise testing, the primary objectives of graded exercise testing are to obtain claudication data. Um, so the main things we're looking at here is to see how long it takes for them to not be pain-free anymore while they're walking, and then how far they were able to walk pain-free. So if you can obtain that data, because it'll be very different for every person who has PAD, then you can accurately create intensity levels for your patient. Also, something different for PAD is that they get the Reliable Ankle Brachial Index, or ABI. So they essentially take I believe it's systolic blood pressure. So they compare the blood pressure in the lower extremity to the blood pressure in the upper extremity, and then they make that a ratio. So depending on what it is, here's some of the scales. There's more than this, but I just put a couple of the more extremes. So if the ratio is less than 0.90, then that means that there's some significant narrowing of one or more blood vessels. So maybe doesn't cause problems yet, but it'll start to. If it's lower than 0.80, then pain may occur during exercise, which, as we said, is called intermittent claudication. And then if it's extremely serious, where the ratio is only zero point 0.3 or less, then these symptoms may occur even when at rest. So, obtaining these through exercise testing would be extremely helpful for you to know as an exercise specialist what are the ranges that we're working with here. Now, they also take a lot of different medication. There's a little bit more overlap with the side effects from these. However, I did compile them. Now, again, this is not one drug, it's multiple and what's possible. But some side effects they may feel are headaches, dizziness, gastrointestinal upset, and then musculoskeletal soreness and pain. Also, to note here, and I mean, this goes for CAD and COPD as well, they're likely taking medication associated with hypertension and dyslipidemia too. So think about the ACE inhibitors we talked about, beta blockers we talked about, diuretics, whatever it may be. They're probably taking some of that too because these cases are almost never just isolated. So definitely, again, take note of what medication they're taking even if it's not specifically for PAD. Now, the effect on the exercise response. So, in terms of intermittent claudication, um, again, we talked about testing for this to see exactly what those timeframes are. But the time to the onset of pain and then to the maximal claudication pain is used to assess functional severity of the disease. So, let's say they walk for 5 minutes and they're pain-free, and then starting from minute 5, they start to feel some pain, but they can keep going and then at minute 10, it gets to the point where it's so painful they have to stop. That amount, that 5 minutes basically, um, is what it is for them. And there is a way to assess how bad it is for them, right? And a note about medication is that beta blockers specifically may decrease that time to the onset of claudication. So, yeah, medication is very important to take note of for all of these populations, but just note that, like, this is a very specific thing that affects people who have PAD. Now, the positive effects of exercise training, again, there's a lot, like all the basic improvements to exercise training, but specifically for PAD, we see an increased leg blood flow. So the capillary number increases and the vasodilation improves um, in the leg. So ideally, yeah, claudication either doesn't occur or it's not as bad. Improved properties of blood. So an example is viscosity. So that's how thick the blood is. So if the blood isn't as thick, then it through moves through the vessels unimpeded. So improves that. And then higher concentration of oxidative enzymes in the skeletal muscles. So there's a lot of really good specific benefits for PAD. Now, in terms of exercise programming, here's an idea. So, in general, the CDD4 recommendations are good depending on the severity, right? But a mode for them can be interval walking. So, kind of like COPD, intervals here are probably a really good idea again because they probably can't sustain any more than 5 to 10 minutes to start with. Frequency 3 times a week, which are our guidelines anyway. And then intensity for claudicators. So exertion to the point of experiencing leg pain is required for maximum benefit. Now, this is really different compared to some other stuff we've talked about. I may have mentioned this in one of the earlier chapters, but typically, um, pain is not the goal of exercise. Your goal isn't to make them feel so much pain in every session that they're with you. However, for claudication specifically, this statement is exactly what is said in the book about it. Exertion to the point of experiencing leg pain is required for maximum benefit. So, it probably won't be very comfortable for them, but I think this is again where you should use your education as a backup for you to kind of show them like, hey, look, research has shown that to see maximum benefit in your exercise, you actually have to go to the point of pain. And again, this isn't for every condition, but for claudication specifically, that's the case. But I mean, it doesn't mean you just work them and never give them a break. Full recovery is allowed between exercise intervals. So, like, it's not a boot camp, right? But just keep that in mind when you're working with people. Um, Now, I actually didn't mention this and I should have. Not everyone experiences claudication when they have PAD. Often it's asymptomatic for them. Um, so for those people, start at 40 to 50% of their heart rate reserve. And then for the duration, start with 15 to 30 minutes. Now, this is pretty individualized. It really does depend on who we're talking about, but that's a pretty good goal to start with. And oh, look at that. That is what we have for chapter 7. So, um, yeah, this will be the general format of all these other chapters. I promise they won't be as long as these two were, chapter 6 and 7. Um, but these were some big ones, and we've probably covered a majority of people that you may work with in the future already in this class. So, hopefully you guys enjoyed, and I'll see you in the next chapter.